I'm just going to talk about the ADLIFE project for the last few minutes of this conference before the closing session. And as you can see here, the number of the grant agreement has changed from the previous slides because this is a new project funded by the Commission under the Horizon 2020 Research and Innovation Program that started in January 2020. The project, the ADLIFE project, the full name is Integrated Personalized Care for Patients with Advanced Chronic Diseases to Improve Health and Quality of Life. And it responds to a call, the number of call here, that was launched by the Commission in 2019 and supposed to address large-scale pilots of personalized and outcome-based integrated care. So this new project has 11 partners and tries to develop and deploy these solutions in 7 pilot sites in 7 different countries. The duration of the project is 4 years. It's a 6 million project. And as I said, the grant agreement number is found here. The partners include not only universities and technical centers, for example, University of Warwick, but also companies like SRDC, Empirica, Every, and Optimalis. So the ambition of the project, of the ADLIFE project, which is in some ways a continuation or built in C3-Cloud, and in fact many of the partners also were part of this C3-Cloud consortium, is to achieve quantified gains in patient health status, preventing unnecessary suffering, slowing down clinical function deterioration, improving patient-reported outcomes, but in advanced and severe chronic patients. So contrary to C3-Cloud, where we address low to moderate severity or in chronic patients, in ADLIFE, we are addressing much more severe and much more advanced complex patients. The other second ambition is to obtain improvements in efficiency, making better use of resources, increasing coordination, and improving working conditions of professionals. And this is a relevant point because it was specifically stressed in the call that that was one of the aims of the Commission when launching this call. The third ambition is to protect the functionality and enhance autonomy of patients, empowering them, participating in decision-making, and adapting to their changing conditions and contexts. In these severe patients, the changing conditions is very important. We're talking about patients that are not going to cure, we are not expecting them to improve the health, but we really are expecting to improve their quality of life and, of course, their autonomy. And finally, we want to demonstrate that this solution can be flexible enough to be deployed at large scale in different environments, in different health systems environment, protecting data access and confidentiality of data. So these are the ambitions of ADLIFE. The concept of ADLIFE is very similar to C3-Cloud. We are organizing a project that is really focused on outcome-based care and with 3 different pillars: person-centered care based on personalized adaptive care plans, supported by clinical decision services based on intelligent tools, and providing a very active role of patients and caregivers through empowered position within their healthcare. The architecture of ADLIFE, again, resembles the architecture of C3-Cloud. It's based on the architecture approach of C3-Cloud. It's based on different platforms, a patient empowerment platform, a personalized care plan platform, CDS set of services, and a technical semantic interoperability suite that within and with a security and privacy suite draws on data from the local electronic health record systems and other ICT systems to provide enough capability and functionality so that we can make a baseline assessment of the patients and follow up and update the initial care plans to adapt to the different contexts and changing needs of these several patients. The idea is that the goals, activities of those care plans during the follow-up of those patients can adapt thanks to patient-reported outcomes, changing information about the context of the patient, so that at the end of the day, the intervention can adapt to continuously to the changes of the situation of those patients. All these are supported not by clinical decision support systems of different types. We will provide in ADLIFE guideline-based suggestions as in C3-Cloud, of course, adapted to the new situation of the patients, but also continuously check the needs and situation of the system and the patients using different scales and heuristic algorithms, and providing new functionalities so that healthcare professional can have continuous information and alerts based on early warning system, based on risk prediction, AI-based tools. The scope of the project is wider than C3-Cloud. As I said before, we want to engage nearly 600 healthcare professionals in 75 different healthcare settings in 7 different pilot sites with different healthcare systems. Altogether, we will evaluate nearly 900 severe and complex patients. This is the inclusion criteria. We are talking about senior patients with severe heart failure on the 3 or 4 state of the NIHA scale, and or COPD patients, also severe COPD patients, with or without different comorbidities. Altogether, we expect that in these seven regions, the impact of ADLIFE can reach nearly 200,000 patients altogether. This is the timing of the project. We are here in nearly month 9 of the project. As I said, it started in January 2020. It will end at the end of 2023. During the first 2 years, we are adapting, customizing, integrating the different tools to the different systems. One of the differences with C3-Cloud is that we want to really take very much into account the legacy systems and the different functionalities that are already existing in those different countries, so that they can be fully deployed and fully maintained afterwards by the different systems. And we will have a full 12-month follow-up of the recruited patients during the second half of 2022 and the first half of 2023. All of it will be thoroughly evaluated from different point of view. So what are the key expectation results of C3-Cloud that we will build ADLIFE on? Of course, the experience and the team insights that the partners in ADLIFE that already have been working in C3-Cloud will provide, but this include the care model, the architecture approach, the methodologies, training, implementations, and so forth, and some of the digital solutions that have been developed and validated in C3-Cloud. But of course, there are further developments in ADLIFE's tools regarding the usability and functionalities. We will try to overcome some of the limitations that we have found in C3-Cloud in terms of the development customizations and, of course, the large-scale deployment of the personalized care planning platforms and functionalities, and adapt them to the new complex and severe clinical conditions that we are addressing in ADLIFE. We are going to extend the clinical decision support systems by means of artificial intelligence-based prediction models, as I said before, and integrating new functions with new skills and heuristic risk algorithms that allow for this continuous assessment of the change of the condition of the patients, so that clinicians can adapt and update their care plans. And of course, we will include more clinical guidelines to address the different diseases and conditions that we are addressing in ADLIFE. Finally, in terms of the patient role, we want to reinforce their role and the self-management. According to the context, we are including these patient-reported outcomes measurement functionalities that will continuously feed the clinical decision support and these assessment tools that I mentioned just before. And we will include these just-in-time empowerment adaptive interventions so that recommendations can be continuously updated to take into account the different contexts and situation of the patients. And we want also to include new functionalities that reinforce shared decision-making around all the care plans that the patients will be following. And that's all what I wanted to say. Open to any questions. Thank you. Gracias, Oscar Casco.